So I will start until they join us. So it is not progressing. Okay. So our eminent panelists are Professor Dr. Ahmed Souka from Egypt, Dr. Hussein Khakan from Pakistan. Unfortunately, Dr. Mathieu was not able to join us today, and Dr. Muhammad Hazazi from Saudi Arabia, and our dearest professor, Dr. Mostafa Nabi. And we are going to discuss the role of scleral buckling as a monotherapy or a combined surgery, and some of the complications that we meet during our practice, and the new entity according to the macular shift or retina integrity in retinal rhegmatogenous retinal detachments. So first we are going to talk about the indication of scleral buckling, and according to literature and the current practice, the success rate of scleral buckling ranges from 60 to 80% according to old literature, with a failure rate between 40 to 20% according to the lens status. So Dr. Mustafa, please can you tell me, according to your practice, what is the success rate of
Actually, now that we have pars plana vitrectomy, we perform scleral buckling for rather very well selected cases, so the success rate is quite high, like 85% or so.
And compared to vitrectomy, is it higher or lower if the case can go for vitrectomy or scleral buckling?
I think it's equal or even better, but the advantage is not that a higher success rate, is that a very shorter rehabilitation and probably a better visual function.
Yes, sure. And Dr. Souka, in a head-to-head comparison of vitrectomy to scleral buckling, some of the literature showed that scleral buckling has a higher success rate. And regarding the re-interventions after vitrectomy, it's higher compared to scleral buckling. In your practice, do you find that your vitrectomized patient require more visits, has more re-interventions compared to the one that you go for scleral buckling?
Well, for sure, more visits. Yes, the buccal cases, select buccal cases, they are the reason, the selection, that have a higher success rate, because they are the easier cases, the amenable case to buccal. I go for vitrectomies in more difficult cases, which would generally have a lower success rate anyway. And the visits, yeah, it's a big difference, of course. For buccal, usually, if you see the patient after 1 week and he's attached and the minimal inflammation around the eye, I see him again once after 1 month, and sometimes I don't see them later. They don't come, they feel fine, they get their glasses.
Yes, great.
So definitely there is a big difference.
Dr. Hussein, do you have the same experience with buckling? Dr. Hussein? Can you hear us?
Hear him? No, give me this one.
This one?
Just give me the...
Which is one?
Can you hear us now, I guess? No? Okay.
Okay, we were discussing the number of re-interventions comparing scleral buckling to vitrectomies in retinal detachment cases. So, do you have the experience, or do you believe that scleral buckling offered the patient less number of visits, less number of re-interventions?
Yes, obviously. The world that we are living is developing country, so vitrectomy costs much more, and it has later on complications with the gas or oil. So it is cheapest way to deal with the primary rhegmatogenous retinal detachment.
Yeah.
If you have anterior break, is the best procedure in young and old patients. Yeah.
Okay. So, Dr. Muhammad, can you tell us, this is a simple rhegmatogenous retinal detachment in phakic patients. How can you manage this case, in your opinion?
Yeah, this is an anterior, slightly posterior retinal break. So, in those cases, I have to be very careful in applying radial sponge to cover the whole break.
So you go for a segmental?
Yeah, segmental in addition to a radial oriented posterior.
Sponge.
So yeah,
okay. Does anybody have another opinion? Okay, you are approve it.
Actually, I put an encircling just to maintain the height of the buckle for long term. And this is an upper temporal break away from the insertion of the superior oblique. I think radial buckle should work very well. In such a case, I don't think I'm going to perform drainage of subretinal fluid.
Okay.
Just a buckle.
This case was managed, yes, with an encircling band and a tire, and this is the early post-operative picture with stable vision. And this is the 3-month appearance with a very stable retinal attachment. But sometimes we have these paramacular subretinal pigmentations. Dr. Hussein, how do you perceive it and how common do you see it in your detached cases?
Actually, this may happen in the cases when you have a very high buckle. And the second thing is, in these cases, you get a little bit fluid later on, because as you can see, the posterior edge of the break is on the sloping edge of the buckle. Even you have put the tire, but it didn't cover it completely. So you may have such like things with it, and later on it may have a detachment when they may get the posterior detachment. So I think So I think we should have a better height and a little bit more posterior buckle.
So do you believe this occurs because the posterior edge was not well...
and the fluid stayed for long.
Okay. So if we drain the fluid, we won't have this RPE.
I mean, it's not like it. I mean, if you have a good buccal height, then fluid gets away quickly, and it when it covers the break. When it's in the slopy margin, it has a little bit seepage of the fluid from there, and it may take longer. And patient usually don't get the good vision in these cases.
Dr. Mostafa, please.
I think this is pigment dispersion from cryotherapy. And if in large break you do a little bit more of cryo, you are going to have this, and this increases with time. Maybe after 10 or 20 years, you are going to find the posterior pole.
Is it subretinal or over the retina?
No, this is subretinal.
Subretinal.
This is definitely subretinal.
Okay.
And
is it of significance?
After a long time, it can be of significance because some of these continue to develop over the years. Okay. And I have seen cases that I operated maybe 30 years ago that the posterior pole is almost completely occupied by these pigments.
Okay, Suka, please.
I agree with Dr. Mostafa. This is the comment I had, that this is probably from the cryo, and the RPE cells disperse downwards towards the edge of the detached area. As regards long term, as Dr. Mostafa mentioned, if they induce PVR, because the source of PVR is the transformation of the RPE cells into eventually fibrotic tissue. If it happens, it becomes a problem. If it doesn't cause any PVR, it's no problem at all.
Okay, Dr. Muhammad.
I think they can affect the visual function without PVR.
Later on, yes.
Yes,
it's
just
like
deposition of pigment under the macula.
Yeah,
like
if they go
laser
under the
extension.
fovea, yes,
Yeah,
I agree. But
Okay,
this
so
is on the temporal side.
let's move to this one. This is a kind of detachment that a male patient presented with a chronic stable detachment for 5 months with this demarcation line over there and atrophied or resorbed anterior flap for this detachment. And he was told by the doctor that no need to go for a surgery now until there was an affection for the macula. Would anyone practice like this if you have a stable detachment for 5 or 6 months with attached retina 0.9 or 1 vision? Would you wait or you move on with treatment?
Do you have an OCT?
No. There's a bisecting macular detachment now.
I think at this stage I will go for surgery. I will do the buccal.
No, at this stage definitely we will treat. I mean, if this presented with a chronic stable detachment.
Sorry, you can repeat the question.
At this stage, all of us will treat.
Yes.
I mean, if it is presented with just that chronic stable tear and very shallow detachment around this demarcation line, would you treat, add a buckle, do pneumatic, or you just follow up those patients because probably they will not develop detachment?
If they have a demarcation line across the fovea or over the foveal area nearby, I wouldn't treat if it is a young
patient. No, it's just demarcation line around the tear. Can you see it?
No, then I will treat it again.
You will treat it?
Yes.
Dr. Mostafa, would you treat it or would you observe for some time?
If this demarcation line is completely surrounding the tear and there is no passage of fluid across this demarcation line, there may be a chance for waiting, but my threshold for operation in upper tears is very low actually.
Okay. So probably we agreed to treat, but sometimes due to the weekend effect, we may postpone one of our cases 1 or 2 days. So do you believe that you ask your patient to lie on one side according to the position of the tear, Dr. Suka? Do you practice this if your case is going to
Sometimes,
be
if I'm postponing the case, like this patient, for example, I would tell him to lie down so that the tear is lower.
Okay.
So I tell him, lie on your right side. If I know that I'm going for 2 days or 4 days for whatever reason.
But this gravitational based orientation or positioning was described when we have a flap like the one before. So in this case, the anterior flap was resorbed. Would positioning the patient would still add an effect?
I don't know, but I would tell him to lie down. I don't want the fluid to increase.
Okay. And
But I agree.
if the tear is temporal in the right eye, will stay on the right side, and if
so,
left,
so that the tear is at the lowermost part.
yes.
The higher the tear, the more
And
bullous
that's
you
to
can get
avoid
attention.
the pulling or opening of the flap, right?
To avoid actually gravitational effect, the fluid goes through the tear and goes down and get more accumulation and
Okay.
lowest. Usually you don't get increased the amount of fluid, less increase.
Dr. Muhammad?
I think in addition to the gravity, you can hear me?
Yes.
Yeah. In addition to the gravity, there were one paper that comparing the ocular muscle contraction and its effect on the subretinal fluid, and they found that if patient was advised to have decrease the movement, the eye movement in a certain position, it found that it decreased the fluid movement and shifting inside the eye.
Dr. Mostafa, please.
I'd like to add one more thing. I had patients with high bolus detachment, and my plan was maybe a DACE technique, drainage and then. So I thought, okay, lie down so that the tear is lowermost, and the next day it's just a simple detachment again.
Okay.
So
this
it
is the
goes
opposite.
down.
Yeah.
Yeah.
This is reversing the
Yeah,
bolus.
I
But I
know.
mean, positioning your patient
So that the fluid
will avoid
actually-
macular detachment. Okay. Dr.
I
Mustafa,
believe
please.
both of them work.
Okay.
Actually, gravity is not about the flap.
Mhm.
Gravity is about having foreign vitreous in contact with the tear.
Okay.
And this acts as a plug against passage of more subretinal fluid.
So
And about the intraocular currents that lead to progressive detachment, I think if you really want to prevent the intraocular currents from causing excessive accumulation of subretinal fluid, you have to have binocular patch. Uniocular patch is not enough.
So this is a new report that published in the American Academy last year, and it was comparing the preoperative positioning regarding the progression of the foveal detachment between the old gravity-based orientation or positioning versus the reduced just movement position. And you ask your patient just to reduce his movement, and it was found that it is superior to what we know about the gravitational positioning. And Dr. Hussein, how you manage or treat this case now? The one with the chronic stable, no, the one on the left, the large one.
Yeah, I will get a circumferential segmental buckle for it.
Segmental buckle,
Yeah.
okay. So, Dr. Tsuka, do you feel or do you believe that this one could be treated with pneumatic retinopexy at this stage, or do you afraid from the viscid subretinal fluid as when the gas bubble resolve and we still have this fluid, it will reopen again?
Viscid fluid will definitely take more time, but this is not what really prevents me from pneumatic. The duration of the tear, despite demarcation line, means it wasn't detached for a long time, the whole of the retina. But still, I don't go for pneumatic except in very fresh cases, very clear-cut tear, localized. Any additional sign of chronicity, longevity of the tear, I don't like to go for pneumatic.
Okay. So this case was managed with circumferential scleral buckle, and this is the early post-operative picture of this patient, and it went well. And this is another case with 58-year-old female phakic patient, hand motion for 2 days after she had a 3-month of pneumatic retinopexy for another superior tear. So Dr. Mustafa, how do you manage this case after she had a pneumatic retinopexy?
Actually, from my place, I don't see the tear now.
Yes. So if you don't have an obvious tear, it's just a suspicious tear in this fold.
There is a saying that you don't know where the tear is, but you know where the tear is not.
Okay.
I may try actually a blind circulage, but given the age of the patient, maybe I think I go for vitrectomy in this case.
Dr. Suka?
I'll put a plan that I'll search for the tear. I expect it to be either in the
I
extreme
mean the
temporal
first choice. Would you go for
buckling.
Dr. Hussein? Dr. Muhammad?
I'll go for vitrectomy. Yeah.
Vitrectomy. So
Yes.
2 vitrectomies and 2 buckles. And if buckle, for those told buckle, is it a circumferential one or just a segmental over the suspicious area? Or if you find the tear during indentation? Dr. Hussein and Dr. Suka?
3 months, a recurrence, probably circumferential band with a segment on the tear. If things look so fresher, I don't feel it's old, maybe a segmental buckle.
Okay. So it went for a segmental buckle and everything went okay. And this is the early post-operative picture. 3 months again later with the subretinal RPE Dr. Mostafa was talking about, and probably it may increase later on. So this is a different case with a 49-year-old phakic patient with an 0.8 vision, and he came just complaining of this black curtain, and we have one obvious tear and a suspicion of a tear under this fold with a paravascular tear, and there was some vitreous hemorrhage down below. So Dr. Mostafa, how would you manage this case?
I think for this case I go for vitrectomy from the start.
Okay, Dr. Suka?
I might go for vitrectomy also.
Why?
I don't like the position of the tear, the superior one. It's a bit more posterior. The edges are rolled. I believe maybe there is suspicious areas more posterior, more down there. They all look more posterior to me than what I like. So I'm between buckle and vitrectomy. I might leave it for operative localization and choose, but I think vitrectomy
Dr. Hussein?
seems sound.
Yeah, I mean it's relatively posterior, but if I will go for radial sponge probably in this case.
And would the radial sponge would
Yes.
be enough, because these tears are at different levels. So you will add 2 indenting matrix sutures, or just one will be enough?
This is vertical one, so I will go with the 2 sutures as the radial sponge in this case. Yeah,
And 2 radial sponges, or one?
one.
Dr.
Because
Muhammad?
because I don't find anything else here unless with the indentation
Sure.
I find.
Dr. Muhammad, would you
So
go
detachment
buckle?
is one quadrant. I
Yeah,
will
yeah,
go
yeah,
with the less invasive. I will go with the pneumatic.
Just pneumatic.
Yeah, just pneumatic.
Okay.
Yeah, superior one.
So this case went for a scleral buckling, and it was encircling buckle, and really it went well, and the vision was stable with this early vitreous hemorrhage and floaters. And the vision kept at 0.8, but the patient came after 6 months complaining of these vitreous large floaters due to the hemorrhage that happened during the detachment. So would you intervene at this point, Dr. Mostafa, if you had the buckle and everything went okay with a vision of 0.8? Would you go for vitrectomy for this floater?
This depends upon how much this vitreous floater is affecting the.
He's 0.8 and he's doing everything well, but he feels that there are some hairs floating in his eyes.
Actually, I won't go for vitrectomy.
Would
at this
anyone
stage.
do flotterectomy at this case? Okay.
Maybe much later.
Okay. So regarding the issue of hypotony with retinal detachment, this is a female with presented with a single-eyed patient, less than 1 millimeter vision, with a macular scar in the other eye, and the IOP was 3 millimeter with a chronic detachment and congested choroids, and she presented with these 2 opposing flap tears. So Dr. Hussein, how would you manage such a case?
Here I will go for vitrectomy, no other way.
And what is the tamponade?
In tamponade you can use SF6 also.
And why vitrectomy, not buckle?
Because I don't want to have the inferior break is relatively posterior. I wouldn't be able to cover it. So I don't want to have a 2 segmental buckle. It doesn't make sense. So so I will go straight forward for this vitrectomy.
Okay.
And this is more bullous, and
Sure.
it will settle down.
Okay.
Yeah.
If I showed you that there is some lattices all around 360 in this case, with tiny small or atrophic holes, would you still go for the vitrectomy and the SF6?
For sure.
And we don't add an additional buckle with the vitrectomy?
No.
Okay, Dr. Mostafa, please.
From the start, I go for buckling.
Okay.
When the eye is hypotenuse,
Yes.
I have a very good chance of closing the breaks very well, even without drainage. And it's far better to have an eye that is less inflamed
Yes, sure.
after in a hypotenuse eye than having severe reaction post-operatively.
Great, Dr. Mostafa. And this case really was treated very nicely with this buckle. And this is the 1 month, just 1 month post-operative. And as we can see, this is the follow-up of the patient that reached from counting finger to 0.3 in just 1 month. And without adding a steroid, just by treating the detachment, the intraocular pressure started to improve and there was no inflammation in that case.
Maybe Dr. Mustafa, if you can add
Sure.
something. During buckle, you have to inflate or push a fluid inside the eye so you can do the suturing without any complication.
This is a good point. And the question is if you do a buckle, as Dr. Mostafa said, would you drain, Dr. Mostafa?
No, I don't think I will drain.
Dr. Shuka?
Just a buckle.
My question was the drainage. You asked it already.
I didn't drain.
Yeah. This is a 50-50 case for me because of the drainage area. If
But as Dr. Mostafa said, if you have a hypotenuse case with a probability of inflammation, would you add the tire or even the band, and then even if you want to go for vitrectomy, it will be less inflamed?
a later vitrectomy,
Yes.
but not same setting vitrectomy.
Yeah, sure. I mean,
Yeah.
better. Yes.
Yeah.
Okay. So regarding the lens status, would it affect our decision? This is a 56-year-old male with a toric IOL for a refractive surgery and presented with this macula of detachment and this just flap there. Dr. Muhammad, how would you manage this case?
Yeah, this is a temporal.
Yes, temporal
detachment,
detachment.
yeah, with the
reaching
temporal
the
break.
macula. Yeah.
So he's with the trifocal IOL or toric IOL?
Toric IOL.
Toric IOL, okay, it won't change much. So I will go for a buckle only.
Buckle, Dr.
Yeah.
Suka. And
Buckle only.
regarding the refractive lens that he has before, the buckling would affect his refractive.
Sure.
So you want to go for a less or more conservative option?
I don't feel that because of the refraction alone, I shift from a radial buckle to a vitrectomy and gas or silk.
Dr.
I
Mustafa.
feel this is a big shift.
Actually, for myself, I don't think it's an issue, but for the patient, it's a great issue.
Yes.
Because the patient thinks that the lens that he implanted is the only
Very
reason
precious.
for vision.
Yeah. So would that affect your decision?
No, actually. But I want to have a very thorough indentation in this case because this size and site of the break cannot account for a detachment upwards. I have to look much more for an upper hole or tear.
Okay. So according to this rationale that in literature that pneumatic retinopexy offer a better visual quality and faster rehabilitation, this patient was treated with pneumatic, as I'm going to show you. But the problem in literature that the pneumatic success is lower in pseudophakic patients. So do you believe so, Dr. Hussein? So if you have the same scenario and you want to treat it with pneumatic, but because it's a pseudophakic patient, you won't do it pneumatic and you will go for buckle or vitrectomy?
I mean, I will go for buckle. I don't want to take chance. I mean, why?
So you straightforward go to the
Go
buckle.
If this is the only one break that you had shown, I will go for buckle.
Okay. So this patient was treated initially with pneumatic and the vision started to improve, but this is the appearance after 3 weeks with this macula of retinal detachment. So Dr. Mustafa, I think you said from the beginning that we have to treat it aggressively. So at this point, how would you manage this case?
What is the cause of detachment? Is it? I think the cause of detachment is a tear in the upper quadrants because the eye remained attached as long as the air bubble is there, and started detachment after the upper retina is exposed. So I expect there is a tear in the upper part of the retina. Since I don't see it very well, I think I'll go for vitrectomy and.
Actually, it was treated with a buckle, and I'm going to show you where the tear was. But in incidence of new tears in the first month in pneumatic retinopexy is around 10%. Do you find this high number of recurrence due to a new tear after your pneumatic cases, Dr. Hussein?
What I tell you, I with my PNR cases, I have some issue. I tell you, maybe my colleagues will agree. In young patients, when I do PNR, I get usually macular hole. The retina gets attached, but usually A couple of cases I got the macular hole. First thing. Second, after the PNR, I get very much severe inflammation in the vitreous, and this vitreous gets very turbid. So I don't prefer the PNR. If the PNR is done, it's a failure, then I will go for vitrectomy, not for the buckle after PNR.
Okay. So this case was managed with this buckle, and there was actually a new tear superior to the one that we saw before, and as Dr. Mostafa said, it's a superior one. So the next issue is the number of tears. Would it affect your decision to do a buckle or not? So Dr. Muhammad, this is simply a straightforward case with a multiple flap tears in the temporal part. Would it affect your decision? How will it treat the number of tears?
Yeah, definitely. From the cases that I have came through, those cases they tend to have even more flap tear every time you treat an area. So such cases, I will go from the beginning with circumferential 360 scale buckle. Just
so it's
to
a
support.
buckle.
Yeah, it's
Dr.
a buckle.
Suka, the same? Is it a buckle?
Yeah, it's a buckle for me, and number of tears is not a major factor to shift me to a vitrectomy, no.
Okay. Would anyone do vitrectomy? Okay. So yes, as our panelist said, this was treated with this buckle and it went okay. But as a comparison to this case with this bull-less superior detachment and multiple tears, around 7 to 8 tears, would that now affect your decision to treat it, Dr. Hussein?
Yeah. In this case, I will go for vitrectomy, no buckle.
Vitrectomy, and what is tamponade?
SF6 is good, all are superior.
And if I showed you that there was a small flap tear lower down, would it still go for vitrectomy?
It's okay with the laser, and it stays for 2 weeks. The gas will cover this one, no problem.
Dr. Mustafa?
I think the same. This tear, but you have to be very cautious dealing with the vitreous base around this tear, because if you apply the least suction, you are going to extend or to induce a detachment.
So it's a vitrectomy.
Yes.
Dr. Suka?
Yeah, I beg to differ. No, I would discuss with the patient. This looks a fresh detachment.
Yes.
And I want to try the buckle. And then I explained that the vitrectomy after the buckle has a very high success rate if we need it. I don't like, if I find an inferior tear like this, to go in and remove the vitreous. It's a phobia I have, let's say.
Dr. Muhammad, would you have a different call?
So those buckles breaks in the top are atrophic holes, right?
Yes.
They're not.
Yes.
Okay. So those cases, even in the presence of foreshore inferiorly, I won't hesitate to go for vitrectomy. And I may, if the patient is pseudophakic, I may place the patient.
No, it's aphakic.
Aphakic.
Phakic
Patient. Okay. So they do very well since there is no detachment. Yeah, vitrectomy.
So 3 vitrectomies and 1 buckle. So astonishingly, she went for a buckle, and the inferior tear was really good tamponaded over the just the band. And from this case, I really learned how the speed up of the visual rehabilitation after doing buckle, and it showed me like a wow effect in LASIK, but in our retina. And this case is attached for 1.5 years right now. So the different issue is when we see an inferior detachment. So Dr. Suka, this is an inferior detachment that is threatening the macula with a higher edge in the temporal area. So where would you suspect to find the tears?
To start with, in the middle area of the detachment, around 6 o'clock in this case, I think there is no superior.
This is the red free showing a higher, okay.
So either in the center, to one side, and so on.
So it's
half
slightly, yes, it's in inferior temporal. And how would you treat this case now?
For me, this is a definite buckle. Any inferior tear which is not very large for a buckle, for me it's number 1 buckling, and I tell the patient you have a higher success rate with the buckle and a better success rate if you need a vitrectomy after you have a buckle in place. So buckle.
Dr. Hussein?
Straightforward intratemporal segmental buckle.
Segment. Dr. Mustafa, buckling or vitrectomy?
Buckling, definitely, but in addition to the segmental buckle, I'd add an encircling band.
Yeah, sure.
Okay. So as I hopefully always agree with Dr. Mustafa, this case was treated with a segmental buckle, yes, with an encircling band, and it went okay. But this is a different case with, again, inferior detachment threatening the macula, but the difference in this case that there was no obvious tear and this suspicious paravascular tear. So would that affect your decision if you don't have a frank, obvious tear?
Yeah, I mean, why I will take the chance? I mean, it's inferior and it's relatively posterior. Even I want to go for buckle, I wouldn't have a much chances. So I will go for vitrectomy in this case. I don't want to take second chance. Yeah.
Okay, even if it is inferior.
I mean, inferior doesn't matter when you have a good vitreous shaft.
So for inferior detachment, both goes in your hands. Okay.
Oh yeah,
Okay.
I do good. I mean, people talk about a lot inferior detachment. The retina doesn't have a laterality like superior or inferior. It depends how much vitreous you get rid of and how much shortening of the retina. The shortening of the retina plays role, nothing else.
Would anyone add buckle, Dr. Suka?
To vitrectomy,
No, just the buckle only.
I will go for both buckle vitrectomy if
Okay.
it's inferior.
Dr. Suka, buckle or vitrectomy or
Buckle
combined?
only again whenever I have an inferior tear, as long as it's not very posterior, or if I feel I
Mhm.
can't reach
I mean,
it.
if it is suspicious,
Buckle.
you will start again with a buckle.
Yes.
Okay,
yes,
and Dr.
yes,
Mostafa?
yes.
Actually, this is a borderline case. It can work with both.
Okay, but which one
I
will you
think
choose?
I'll make a decision according to other extraocular factors, like how is the patient fit for general anesthesia?
Yes, it's fit. It's phakic with some cortical cataract, as we can see.
Maybe a buckle.
A buckle. Dr. Hussein, would you add anything?
Main issue is when you have a suspicion of this break, how you will get out from your suspicion. You want to do the buckle for a suspected break? My question.
For me, yes, I will go because inferior tears.
I mean,
with a
for
buckle.
example, this detachment is not from this break most probably.
Why? If it is chronic, it could be from
I
this
mean,
detachment.
look at this break. If it is suspected, look at the nasal side, the high
Yes.
end of the fluid.
And you are going
This
to see.
this break is not going to get so much high
this is
fluid.
the next question, and I will see
Okay.
according to the orientation of the detachment and the longevity of the chronic
Yeah.
detachment.
I said I'll put a buckle, so
Okay.
I can answer part of this.
Sure.
For one thing, this is an ultra-wide field photo steered inferiorly.
Yeah.
So
yeah.
this tear is not posterior, this tear area, let's say, okay?
Yeah, from the aura, it's a little
It's
bit.
already anterior, okay?
Okay.
So how do you say this suspicious area has a tear or not? Cryo application during surgery.
To highlight up.
Suppose it's not the tear, okay? Then I have something peripheral, small, minor tear. I'll search for it with cryo. I didn't find anything. I drain, I put a band, and then I postpone everything later on. I did this for, let's say, in the area of 15 to 17 patients.
Mhm.
I have 16 attached patients.
Okay. So it was managed with the buckle encircling, as we can see, and okay, it's again went well. So regarding this detachment, as we can see, it's coming as a trough from the upper part, and this is the orientation that was described by Lincoff, as we all know. So, Dr. Mostafa, how would you treat this case?
I don't see the tear.
It's at the edge. It's probably I would have magnified. It's at the edge of this lattice, at the green arrow.
And I think a radial buckle with an encircling band.
Okay. Would anybody do a vitrectomy? It went well, yes, as they said, with a buckle, and this is a different one with a 26-year-old phakic male, counting finger 2 meters, with a unclear history of trauma, temporal cortical cataract, and on magnification we suspect to find that the tear under this cortical cataract. But due to the orientation that we have for this tear, could it be a temporal tear? Dr. Mostafa.
No, if it is just a lower detachment, it can be a temporal tear. But since there is a nasal detachment, I believe that the tear should be somewhere in
And
the...
that according to Lincoff rules.
According to Lincoff rules, but actually Lincoff rules is not foolproof.
My question is, if it is a chronic detachment, could Lincoff rules still apply?
Yes, in most of the cases, yes.
Okay, Dr. Suka, would you add anything?
One, they still apply. Exceptions exist. So I'll go into this surgery thinking I'm trying to find the other tear that explains it. I keep finding, trying. If I don't, yes, it could be.
Yeah, it could be.
Could be,
Okay.
but an exception, yeah.
Yes, this was an exception, and this was the only tear we found, as we can see over the band and the buckle, and it went well with some residual subretinal fluid inferiorly that we are waiting to go.
But, Dr. Mostafa, you're applying a 360
Yes.
buckle, right?
Yeah. It probably could be in the
so you
periphery.
may have another break supported by the buckle,
Sure,
even
but we
without
found
laser
that
was-
I'm with you, but we found a tear, large tear under the cataract at this only temporal position. That's what I'm asking, and it's going to be clear up with this case. So this is a chronic detachment case, and there was a tear elsewhere in the periphery of the retina. So, Dr. Mostafa, how would you manage this chronicity?
Actually, how old is the patient?
52.
I think I do buckle, trial of buckle at first.
With this chronicity.
Yes.
Okay. So that was my question, if the Lincoff rules apply for an old chronic detachment, and in this case the tears were only found in the inferior temporal part, and due to the chronicity it started to go from these tears under that area, the whole retina, and it detached the whole retina, and it causes these fibrosis and these wrinkles, as we can see, and it again was managed with a buckle, and this is the early picture of this patient, and there was no other tears. So I believe that Lincoff rules, when it was published, that it was telling us about a fresh detachment, because if it is a longer standing, definitely the orientation of the fluid will differ. And would anybody do combined vitrectomy and buckle for inferior tears especially? Do you add a buckle to your vitrectomy, Dr. Hussein?
Yeah, I mean, if I have a pediatric case, I usually put the encircling band and do the vitrectomy if it is needed, in pediatrics for sure.
Okay, this is a review that shows that adding a buckle to a vitrectomy for inferior tear didn't add anything at it. They were both almost the same. Regarding the pseudophakic, I have to go through rapidly for the sake of the time. This is a pseudophakic retinal detachment with no obvious tear, 40-year-old male with a cataract surgery 4 years ago. With this bullous detachment, Dr. Suka, how would you go for this case without an obvious tear?
I'll search for it and try a buckle.
Buckle, Dr. Mustafa.
Vitrectomy.
Dr. Hussein. Buckle, Dr. Muhammad.
Superior pseudophakic, I will go for vitrectomy.
So 2 vitrectomies and 2 buckles again, and this case again went well with this buckle and very rapid rehabilitation after 4 days. But this is the appearance after 10 days of the buckle with the hand motion vision. How do you describe it, Dr. Mustafa? What happened there?
The retina is folded. Is
Yes.
there a giant tear?
Yes. So this is a giant retinal tear after adding a buckle in a just pseudophakic case. So how do you explain it, Dr. Hussein? Is it an acute PVD that happened at that time after the indentation with a buckle?
Yeah, probably either it's PVD, either there's a small break that may have joined the previous one, and then PVD, and they have tear along the circumferential.
And open this large tear.
Maybe it's maybe like it.
So it was managed, as we all do with vitrectomy, and used to add a bubble, gas bubble. Would anyone go for a silicone in this case?
No.
No, we're all gonna love the gas in this case, and you're lucky to have the band already in place.
Yes.
It's better
So
than
it
adding
added
it.
to your success,
Yeah.
right? Okay.
Yeah, I think so.
So this is the literature that shows that again in pseudophakics the buckle has a less successful rate compared to vitrectomy, especially in pseudophakic cases. In a trauma case, this is a 14-year-old male with a history of diminution of vision after a blunt trauma, and as we can see, there is a superior detachment without an obvious tear, and we have these bands running in the vitreous. So Dr. Muhammad, what is this sign, and what does it make you suspect?
So this is a chronic...
No, this is a fresh detachment after a blunt trauma in a child. And we have these running strands, upper and lower quadrants, with a localized superior detachment. Would these strands add to your decision, or do you suspect anything if you can see this detachment after a trauma and these bands in there, Dr. Hussein? So this is the...
vitreous-based detachment.
Yes, sure, yes. This is what we call the vitreous-based detachment, and this
Bucket
is...
fine.
Yes, this is the vitreous-based detachment, and this is the appearance after we add the buckle, and this occurs after trauma, and this is 100% sign for that we have a dialysis in this patient, and this is the area of the dialysis that was only treated, and this is the only option, I think, in my opinion, for treating a dialysis. Would anyone do a vitrectomy for a dialysis?
Actually, this is a version of vitreous base.
Yes.
Most probably it will have a dialysis, Definitely, buckling is good for dialysis, but my experience actually with vitrectomy for dialysis is not very bad.
So it works.
It works.
Yeah.
It works.
In a 14-year-old?
The age is a factor,
Of course.
Okay.
but if it's an older age, I think vitrectomy can be a
I wanted
solution.
to add the same comment
Mhm.
that I do buckle for all cases of dialysis, but it's not the only option vitrectomy works.
So regarding a chronic detachment, I would like to invite Dr. Mostafa to present his case to us, and I would like to go rapidly through it because we are very short in time.
This young man presented with a drop of vision that occurred some months ago. He has a lower detachment with a lower temporal lattice. The retina looks quite tense in the lower part with subretinal fibrosis. The red arrow points to a subretinal cord of fibrous tissue, while the white arrow points to a sheet of fibrous tissue. At that time, the patient declined surgery. He refused to do surgery. Next, please. A few months later, he came with 0.2 vision, with a drop of vision, probably due to interruption of the outer fovea. At this time, the patient asked for surgery. Being young, the plan was to perform tire and the band and drain as much as possible, then inject the biggest air bubble, trying to negate the effect of subretinal bands. But while doing surgery, I started drainage. Some subretinal fluid came, but it stopped flow. So I asked myself, why should it stop flow, and what's my next step is going to be? May I ask the panel about this?
Yes, rapidly, please. Mhm.
Well, the stoppage of flow, for me, it's the same as any other situation that impedes flow. The choroid can move in and you can get blockage. Maybe subretinal glands moved in and blocked it. Incarceration can happen. But as regards the next step, which I feel is more importantly, I would continue the surgery because chronic inferior detachments, they respond better than expected in my hand when you do buckling and you don't go to vitrectomy.
Yeah.
Next, please. Ophthalmoscopy showed that there is no incarceration, but in those chronic cases, there may be two phases of subretinal fluid, a thin phase that comes easily and a thick phase that remains in. Anyhow, I'm deprived now putting a large air bubble, so I just pulled my buckle up, and 2 weeks post-operatively, I had this retinal detachment, but at this point, the macula is attached, so I decided to do nothing and wait. Next, please. In هو العيان بيشتغل بره مصر. Then the next summer he came with improvement of visual acuity to 0.5. 2 years later, now he has 0.7 vision, and this is the lower retina with the subretinal bands, and this is the site of drainage that I had with no retinal incarceration.
Okay, great.
And this is what they call it. No news is good news. So patient disappeared. That means this is a good sign.
So the next issue, would the fellow eye affect your decision when treating a retinal detachment? This is a 58-year-old male with a lost right eye due to multiple interventions of vitrectomy and silicon in and silicon out, and he presented with a recent drop of vision to hand motion with a mature cataract and retinal detachment in the ultrasonography, as we can see. So he begged us and he asked if we can manage this kind of detachment without going to vitrectomy as an initial surgery. Would any opinion come to your you can offer to your patient? Mature cataract and this kind of detachment?
Yeah, I mean, it's a little bit tricky. I don't know. In this scenario, I mean, in very good hand, you can go for phaco vitrectomy, but if it is a mature cataract, you can't see the break buckle will be of not good.
Dr. Suka?
I understand that you're asking for if you remove the cataract and we stop and we go for a buckle, obviously. I tried it 3 times before. It worked fine as long as there is no PVR.
Could you offer your patient a phaco buckle? Is it valid for this case?
I don't offer it. You said the patient is dying for it.
Yeah. I mean, yes.
If he dies
Is
for
it-
it, I would do it, but I'll tell him if operatively it's not amenable
Yeah,
for
yeah.
buckle, I have to shift to the
He
vitrectomy.
asked just an initial surgery.
And I put a suture in the wound. I don't leave it sutureless.
So
operatively.
he went yes for the idea of phaco buckle to remove this hard cataract, and we go for a fundus examination after hanging the muscles in a regular buckle case, and we found the tear and we added the buckle, as we can see. So if you are going to do this maneuver, would you do it simultaneously, or you just remove the cataract in another setting you can do the buckle?
For me, the few I did simultaneously, of course.
Dr. Mostafa, would you add any?
Simultaneously, yes. I did it many times. It works.
So it's a valid option for
Yes,
your
it's a valid
cases.
option.
Okay,
Yes.
Dr. Suka, please.
I'll tell you why you have to do it simultaneously. You did a cataract surgery. You might not be able to see the fundus in the next week. Patients come out with a nice clear cornea and suddenly it's a bullous keratopathy, endothelium cell loss. So it might be the only
So-
chance to fix the retina.
Okay. This is the Optus image 3 years post-operative, and this patient required the vitrectomy and the gas 1 month after the initial surgery for a new inferior tear. And this is the appearance. He is left aphakic with a vision of 0.7. So would any of you believe that adding a buckle increase the success rate and avoid re-intervention and silicone in this case, Dr. Suka? Yes. So how many yes? Dr. Muhammad, Dr. Hussein?
You mean the patient is recurrent after a buckle?
Yes, 1 month with a new tear inferiorly.
If it is an easy buckle, I'll do it just to sleep.
No, it's the same patient. It's the same patient.
هو نفس العيان.
Yeah, this is the appearance after 3 years. But just after the buckle, he required a vitrectomy and the gas for another inferior new tear. So, and he is stable for 3 years. With the buckle we added at the initial surgery, increased the success rate in this case?
I don't think so. What controls this is how meticulous you deal with the vitreous in the lower area.
So another issue is combined in GRT. This is a 11-year-old male present with this GRT, and we went definitely for vitrectomy, and as we all treated, remove the anterior flap if it is large, PFCL, then we are going to massage, remove the subretinal fluid, doing the laser, and in this case I used silicone and I added a band, a 360 band, and this is the tightening of the band. Would any of you add a band to the GRT case if you're going for vitrectomy? Dr. Hussein, no.
I know.
Dr. Mustafa?
Never.
Never. Dr. Suka?
The inferior 180 degrees, I prefer putting the band.
So this is the appearance of this case at the time of the silicone oil removal, and it is at 6 months. So Dr. Muhammad, do you believe the buckle had an effect or not in GRT cases?
No, actually, from the first place, I don't
You
add a
don't
buckle because
in
it,
GRT cases.
it increased the cases of the chances of slippage of the retina. So
According to your opinion, and this is actually yes, this is the Cochrane library, and it shows that there is no added value of adding a buckle to a GRT case. Okay. So this is the fellow eye of that patient, and it has a white without pressure. Do you treat a white without pressure in cases of joint retinal tear? Do you believe it requires treatment? Dr. Suka, yes. Would anyone wait until it progressed to a detachment?
Actually, I won't treat just white without pressure. But if I have lattice, I'll do.
Okay, so according to literature, yes, it's mandatory to add a 360 laser to the periphery of the fellow eye in a retinal detachment with a GRT, and some advocate to do what is called the Cambridge prophylactic cryotherapy for the periphery that was applied in the Scleral disease. And despite that we did the laser temporarily, he got this inferior detachment that was treated, yes, with a buckle, and he is now stable. And I would like to invite Dr. Muhammad to present his combined case with drainage of SRF and the silicone oil with the band around the eye.
yeah, so this is a 56-year-old male. He presented initially with inferior detachment. It was initially treated with only vitrectomy and oil. However, he came back 1 month after with inferior detachment. So the idea here was how to remove the subretinal fluid, drain it without removing the buckle, if you have the chance to leave the oil in place for certain cases. So this is where I'm trying just to, after I place the insert implant, I am attaching the silicone oil in the infusion cannula. and with the controlled infusion of silicone oil from the machine, I'm draining directly the subretinal fluid with the either with the extrusion cannula or the back flush. You can see the retina has flattened under the oil, like if you are doing the same scenario with the direct BFO oil drainage. The patient post-operatively went very well. You can see the last stage, which is the addition of the laser around the break. Maybe these cases you have to do an scenario when you want to leave the oil in place in cases of pediatric cases, or if you have like pregnant lady, or you have any scenario that you need to leave the oil in place. This is the post-operative optus.
Did you do a retinotomy to remove the subretinal fluid, or you used a tear that was already there?
Yeah, it's I tried to do retinotomy, but it's not easy to do it under oil.
Silicone. Yeah.
So I used the original cause that break.
May I add a comment?
Yes, sure.
I am with you, Dr. Hazazi, for working under silicone oil, absolutely. But I beg to differ about addition of the band. Because if you notice at the end of surgery, the tear is the concavity of the elevation. And I think this is not the best situation for the tear. Subretinal fluid may accumulate later on.
Well, I have a complex comment here. I totally agree with Dr. Mostafa that under silicone, I do lots of cases. Drainage, I agree totally. Through the tear, retinotomy, I've never done this before. It works fine through the original tear. But number 3, in these cases, I would try to treat it initially because it's an inferior tear with the buckle. Mm-hmm. A big chunk of these patients succeed. Another can go both ways, and some of them might need an additional support. But if you start with the buckle, you'll probably finish 70% of them with the buckle only, in my opinion.
Okay. So the last and next entity, what is called the macular shift or the retina integrity that we hear about these days. And this is a case in the upper left that was a tear with progression of the subretinal fluid, and it went with pneumatic retinopexy, which was complicated with this kind of detachment with vitreous hemorrhage, progression of the tear, and it reached the macula. So it was managed as vitrectomy, subretinal fluid drainage from the tear, laser, and then we add a gas. And on follow-up of those patients, we found that there was some shift of the superior temporal arcades from its initial place, and this shift is progressing along the first year. And if we compare, this is the first month, the third month, the 6th month, and this is after 1 year. We can see the imprint of the initial position of the vessel compared to the what we have after 1 year. And this was a vitrectomy straightforward case just with a gas. In a comparison to this more complicated macula of detachment, and she went for a buckle, and we compared the shifting of these vessels from its place. These are the visits of this patient along 1 year, and there was no 1 micron of shifting of these superior temporal vessels. And this video was published in the American Academy keynote lecture for Skippins, and it explains well the idea of shifting of the retina from its place. So we all know that there are some subretinal fluid present in the macula, and when we shift from fluid air exchange, this will stretch the macula and push this fluid away from this area. And because the retina is elastic, it's going to move the mosaic of the cones, which will elongate them and displace the cones from its place, leading to what we know as anisoconia or metamorphopsia. And this is how we can measure this displacement from its place with shifting of the vessels from its original place due to the elasticity of the retina from its place with the movement of the subretinal fluid to a different position, leading to what we have a cause for this anisoconia. And this was reported and documented nowadays in the PIVOT study that showed that there is a superiority regarding the metamorphopsia and the long-term sequelae of this shifting of the mosaic of the cones, raising the pneumatic retinopexy over the vitrectomy as a visual recovery and visual rehabilitation. Do you have this belief in your cases that the more conservative as buckles and pneumatic are better visual quality compared to vitrectomy? Dr. Mostafa, please.
Actually, this phenomenon can be very well demonstrated by fundus autofluorescence. And I believe closing the brakes and allowing a very slow absorption of subretinal fluid is associated with much less displacement. So buckling and maybe pneumatic retinopexy are less prone to produce this.
Dr. Hussein.
I mean, even in vitrectomy, if you leave little bit fluid at the macula, it has a less incidence of macular shape. So it depends on the fluid that you are leaving under the macula at the end.
So we all try to leave it dry. So, but still there are some SRF below the retina in every detached case. So do you have the sense that vitrectomy offers a more stretching and more displacement of the vessels in the macula compared to pneumatic and scleral buckling?
Yeah, obviously. Vitrectomy has more, but if you leave little bit fluid, it will be same comparative as buckle.
Well, Dr. Hussein is mentioning is how to treat the problem the vitrectomy have shown us, but the buckles don't do that as much. I think because the foreign vitreous, the vitreous remaining in the center has some role. Still, there is something not so fluidy to allow this whole movement. But yes, buckles do this much less than vitrectomy.
So again, if you do a vitrectomy during the drainage, this is a very fast drainage of the fluid, and sometimes you can see the shifting of the fluid and from its original or anatomical position. So yeah, I will definitely believe that pneumatic retinopexy and buckle has less shifting.
So finally, in the last minute, I'd just know your opinion about reviving the buckle, or is it still will be a valid option for treating your rhegmatogenous retinal cases? Will it die at any time? Dr. Hussein, it will persist?
No. I learned it from my mentor who was doing daily the buckle. So I did buckle in routine, and my fellows from many years, they are doing the buckle. So it's not going to die in my area,
Dr.
at
Mustafa.
least.
Sure, Dr. Mustafa.
Definitely it is dying, but it is our duty to revive it.
Dr. Suka.
I understand it was dying, but it's definitely not dying because people need it. They came back to need it. They will need it, and it will come back to its original place. It's an important option. It's obvious from our decisions right now that we do it a lot with successful cases. Yeah.
Dr. Muhammad.
You can say it's not dying because its indication and importance is still there. So it's not like,
right?
for example, doing a vitrectomy with 20 gauge rather than doing it with the microscope. So there is an alternative. So still it has its role. It's important, and I will not die for sure.
I would like to thank you all. I would like to conclude this session and thank you very much.